everybody. Welcome to Open Office Hours. So today we have a guest lecturer who is Dr. Robert Baric. He is a chiropractor and his specialty is neurofeedback. And so he's going to be talking a little bit about using QEEG neurofeedback for things like anxiety, depression, insomnia, as well as things like ADD and ADHD, which is exciting. Here we go. Hi. Hi, can you hear me?
Good afternoon.
Great.
Sorry about that delay.
No worries. So well, thanks for coming to Open Office Hours. We are a group of mostly midlife women who are trying to learn more about our health. And this is going to be so helpful for everybody so they can kind of get to know you and see if using QEEG is something that is going to be helpful for them. So for those of you who don't know, this is Dr. Rob Baric. He is a chiropractor and his practice is called Baric and Dr. He has offices in both Cary and Raleigh, and he is a specialist in neurofeedback. So maybe Dr. Baric, you could kind of start off and give us a little bit of background about neurofeedback, kind of what it is and where are we coming from here?
Sure. So neurofeedback started in 1965 with NASA. The astronauts were having seizures around the rocket fuel. So they bring in a gentleman, Dr. Baric, he conditioned, and that's where neurofeedback started. Everything is based on data. Came in EEG and what is that, 57, 8 years later? You have a good signal? Are you hearing me?
Your signal's kind of choppy.
Okay. So I just got rid of a VPN, so hopefully this will be a little bit better. So yes, 1965 neurofeedback started. Everything is based on data. They come in, they do a QEEG, and that gather basically 20,000 data points. And from that data, we're able to figure out how a person's brain is working and try to optimize it. Tons of research on it. And again, it's just a tool in the toolbox for therapists, especially big three conditions we see are ADD, ADHD, anxiety, depression, and sleep issues.
Mm-hmm. And so just to kind of walk people through, the QEEG is sort of like a cap that people are going to put on their head, right? And then there's some electrodes there. And I'm just wondering, like, I have a lot of hair. How is that going to work with getting the electrodes on my scalp?
So it is a cap. It's a cap. Think it almost like a swim cap. It's connected to the computer. And the technology is such that you don't need much electro gel to make a good contact. I mean, dreadlocks are usually the hardest, but I mean, your hair, doc, no problem. Again, but when you go out, you're going to want to go home and shower because there's gel in your hair. Don't go out with people.
Okay, so that's good to know. And we talked a little bit about, so anxiety and depression, insomnia, and ADD, ADHD. I know there is some information on using QEEG for migraine headaches as well. Is that a condition that you've worked with much or have any interest in or response on?
So migraines, we see people with migraines, the answer is yes, but they're usually coming in with some other factor we're kind of treating at the same time. As we all know, migraines can be very multifactorial. Do I do neurofeedback for migraines exclusively? Probably not, but I will use it with other tools that I have in my clinical experience. Is that acupuncture? Is that nutrition? Is that some other things that often are times, I mean, progesterone. Right. There are oftentimes cofactors or co-contributors to that migraine.
Right.
Other conditions that we're going to see are like, I'm sorry?
No, go ahead.
So in the female really world, we see a lot with chemo-induced peripheral neuropathy. So they've had some type of a cancer treatment, and the cancer treatment, the chemo, et cetera, was awesome. It either killed or slowed the cancer, but there can be residuals, that neuropathy, either in their feet or their hands, or chemo brain. That is probably the biggest thing in the middle age to later older females that we're seeing them for either some type of a treatment, secondary side effect. Again, they're alive, which is great, but they have some residuals that aren't really desirable.
Sure. I see a lot of midlife women getting diagnosed with late onset ADD or ADHD, which I think oftentimes as our hormones are changing and estrogen is so readily involved in our memory, as that's changing, we may have a harder time with kind of short-term recall and those kind of things, and that can kind of present like ADD. One of my concerns is that many women in the midlife transition are also often having their progesterone levels are falling. They're feeling more anxious. And so if they're in the conventional space and they're getting treated with a stimulant medicine to help them focus, we're often exacerbating anxiety on the backside. So maybe you could talk a little bit about how QEEG works for attention and kind of what someone might experience with that.
Okay, so in the brain, think of it as almost like you lift the hood of your car, and there's different parts of the brain really regulate different things. Attention is an issue. I mean, in the ultimate hyper-distracted world that we live in, but attention definitely is an issue, and attention is classically in the frontal area, so the frontal area and the prefrontal cortex. And the QEEG is really going to tell us two things. It tells us what is working faster than it should. Mm-hmm. And I tell people, we're all out on a bike ride, but your front of your brain is on that bike you learned on, that one gear bike. You're pedaling super fast, but really not going anywhere. Mm-hmm. And that's what the stimulants do, is they just give you Red Bull so you pedal faster. Right? The neurofeedback is primarily to try to fix the gear so you can get into all those frequencies. But the data is really going to tell me which areas are the most abnormal according to the normative databases. And if it's in the front, that's oftentimes with attention issues. We often see that combination of anxiety and attention in kids that have learning disabilities or autism. So it's anxiety primarily treated in the back of the brain and attention primarily treated in the front. But this is what makes this very unique, because the QEEG, for many years, they were just playing what I call whack-a-mole. If you have this symptom, treat that. If you have this symptom, treat this. And as we had talked about, there's various devices online. And in my analogy, it's like that size 7 shoe. If you have a size 7 foot, you're in heaven. If that's your brain pattern, that can be a very economical way to make some real nice changes. But probably 60, 70% of the people don't have that size 7 foot. They need a more customized protocol or customized treatment. And that's that QEEG, which is, again, it's just listening to the brain. It's not hurting you. It's not a CAT scan. It's not an X-ray. It's listening to the brain. It takes about 20 minutes all in by the time we get you set up. But that really allows us to be super specific to that person's unique presentation.
So just so you guys are in the loop, Dr. Baric and I talked last Friday, and one of my questions was referencing something that's an online tool. So that Muse headband device that we've talked about sometimes in here, like he's saying, it's kind of a one-size-fits-all approach, where you put on the headband, and when you do the little thing, if you make the birds chirp, then you get more rewards, right? And so I was kind of asking how what he has to offer is different than what we can get online, and what he has to offer is a lot more specialized. So he's actually doing an assessment to seeing which parts of the brain light up greater or lesser, versus the Muse device is sort of fixing the most common problem without doing an assessment. Would you say that's fair?
That very accurate. So that's very, very accurate. And again, it is life-changing if you have a size 7 foot. It is life-changing if that's what your brain needs. And I always try to use the most economical way. So, people come in and they say, look, I have this, I found this online, try it. Let's talk in 30 days. If it's resolved, fabulous. If it's not, then we can do the more specific to each individual scan. And the great part about it is it's $100. I mean, it's $100. It's not free, but it's not crazy money. and it's safe. So it's not sending x-rays in or injecting things to get contrast. And that really allows for a very, very specific about you, the individual's current state.
So if someone wanted to pursue this, they would come in, they would get take a history, right? Kind of get what their issues are. They would do the 20-minute assessment with the cap on, with the understanding they're going to have some gel in their hair, so they're not going to want to go to a job interview afterwards. And then the treatment kind of moving forward, my understanding is typically you're starting to see changes around after 20 sessions. So could you kind of walk us through what that would look like in terms of time, travel, all those things?
Okay, so let's kind of work through what a process would be. I would do a history. We would do a scan. The scan tells me if that individual is even a good candidate for neurofeedback or not. Why? Your brain weighs 3 to 5% of your body, but consumes 25% of your calories. Mm-hmm. You and I know you have, I tell people you have 4 brains. You have a right brain, a left brain, a thyroid brain, and a gut brain. And that initial scan tells me, is your brain in a good metabolic state to even try neurofeedback? About a quarter of the people's is not. And then further diagnostic workup has to occur. So let's say you're a good candidate. A neurofeedback session, you come in, you're just watching TV. Say, for instance, people have the area of the front of the brain is not working. I put a few little electrodes here. These are just listening. So this is like a stethoscope listening to your brain waves. And you're watching something on TV. It could be Parks and Rec. It could be Seinfeld. It could be something just mindless. And when your brain is doing what we want, I reward you with a perfect picture. And if your brain is not doing what we want, we take the picture away. So at about session 10 to 15, the individual starts seeing the difference. At session 5 to 10, the people around you start seeing a difference. And we get to session 20 and we stop and we recap. So 3 things need to occur at session 20. Number 1, they need to see a difference. Number 2, the people around them need to see a difference. Number 3, I'm able to compare data round 1 to data round 2, and I want a 20% or greater improvement. Mm-hmm. I tell people, most people need 40 sessions for it to become their new normal.
Okay.
Permanency is permanent, barring a concussion. Concussions, I've seen backslide. Ideally, so there's 2 things. We have our Cary office, Raleigh office, but we also have remote training. So for instance, Saturday, like I'm in the office, multiple people, they fly in, they come in the night before, we scan them, we give them equipment, and they go home. Currently, Saturday is they're coming from out of country and from out of state. And if we can help them, great. If we can't, sadly, I don't know a way around that. But there's remote training for busy people. Mm-hmm. Twice a week, ideally, for a session. 3 times, twice a week's a minimum. 3 is ideal. And that's kind of they'll get the best results, shortest amount of time.
And your session is just about 20 minutes?
So a session in office is about 35 minutes.
Okay. All right, that's really good. I have a couple of questions, and this may, you may need to redirect me, but sometimes when patients are feeling stuck, maybe they've had a history of trauma, maybe they've had long COVID. A lot of times we'll look at these limbic system retraining protocols that their nervous system is stuck in a disease state. Do you have any kind of thoughts on limbic system retraining and how this is, obviously this is different, right? That's just a one-size-fits-all protocol, assuming that's the problem without any assessment. But any kind of thoughts on the use of QEEG and neurofeedback with a history of trauma, either psychosocial trauma or medical trauma?
Okay, so the COVID is usually a frontal lobe executive function cognition issue. Mm-hmm. And at the same time, it's a toxicity issue. It's how do you get the carnage from the dead virus out? We do see a lot of long COVID. Most of them respond very well, but again, it's all based on that initial data. Got it. Limbic system is a different animal. Limbic system are those PTSD events and what I call the emotional junk. The neurofeedback that we talked about so far is probably what 95% is delivered in the United States. And that's when your eyes are open or eyes closed, operant conditioning. So big name operant conditioning, big name behaviors, and real world puppy training. When the brain does what we want, we reward you with TV. When the brain doesn't, we take the reward away. When we get into those trauma histories, there is a different form of neurofeedback called alpha-theta training. And it basically, we put people in this kind of sleep-wake state, we call it twilight. And we're working on a thing in the brain called the default network. Why do I bring that up? The default network is integrally involved in the limbic system. And it's just like mama. If your default network system ain't happy, ain't nothing happy. But it really helps people get into that calmer state, that purging a lot of the PTSD, in addition, creativity. So people just come in for creativity and just internal calmness in this insane world we're living in right now. Right.
So alpha waves, we're doing something to promote more alpha waves. Alpha waves are sort of a state of flow, creative flow. We're calm, we're focused, and we're creative, right?
We're looking, because just before you fall asleep, the alpha waves and the theta waves invert. And when the theta are above when the theta waves are higher than the alpha waves, just as we're falling asleep, that's what we surf. We want you to be in that wave, because that's when a lot of neuro and emotional integration occurs. So we kind of tease you and put you into that I'm almost asleep, but I'm asleep, but I'm not asleep mode. And the brain, it happens to all of us when we go to bed, but we want to extend that out to 10, 15, 20 minutes. And again, that's when the brain really, really purges a lot of the emotional sludge and junk that builds up.
Okay. So when you're making a decision about if you're using sort of traditional QEEG, sounds like it's a little bit more focused on the frontal lobe, versus this alpha theta, kind of a different strategy, are you making that decision based on exclusively their history, or are you combining their history with the initial brain scan? How are you making that decision about which route you're going to go?
So kind of two clarifications. When we're doing the neurofeedback, we're going to work on every area of the brain. So it's not just frontal lobe, but primarily for attention issues, it can be in the I usually start off, we're going to start with this more traditional neurofeedback. And then after some intermediate where they're in a much more stable state, either anxiety, depression, attention, the person needs to be in a good emotional state to go and start cleaning out that junk. I usually do not jump straight into that, but once we get into that, the vast majority really like it, because it just says, hey, I'm calmer, I'm responding, I'm not reacting. I'm at a peace. I have this internal calmness that I've never felt or haven't felt in 40 years, which is priceless.
Right. And like I mentioned, like, the world is crazy. We're sort of training people almost to have ADD with social media and how many likes, and this sort of, no one can just sit and breathe for a minute. We're always looking at our phones. Who couldn't use a little bit of this after the pandemic and everything? Like, it's just, who doesn't need some help here? It's just lovely that there's some drug-free, or even, I would argue, some supplement-free options, because, a lot of our community is, tired of taking pills every day, even if they're herbal things, right? It's just one more thing to do. So this is such a great option. So you talked about that there is some permanence, in the sense of, aside from concussive brain trauma, that this tends to have some permanence, which is really helpful, I think, when people are thinking about making an investment. Any concerns about any negative effects of neurofeedback, or any kind of side effects that people should be on the lookout for?
So let's answer that and then come back to If there's two things. First of all, if they're on a benzodiazepine coming in, then I always try to work with the prescriber to get them on some type, because benzodiazepine really prevents progress. And we don't really know how that works, but we know that if you're on a benzo, I'm not a huge fan of them. They're pretty wicked medications. And if you can get on something else, that's positive. Okay, so now you ask a question of risks. The two things that we have seen are, if people come in with just primarily depression, as we start working with them, there can have a brief period of about 1 to 5 weeks, 4 or 5 weeks, where anxiety can go up mild, moderate. That's with people that are hardcore depression, where their alpha waves, which should be in the right side of the brain, are higher in the left. And the second thing is, it's really pausing treatment between session 5 to 15. And I use the analogy of I'm rehabbing your kitchen and everything's out of your kitchen and in your garage. You don't want to fire your contractor then. We have to put some stuff back. So those are the really two risks that, not really risks, but areas where you could get an undesirable result in pausing at session 5 to 15, or having that short period of time where that increased anxiety occurs. And it probably happens in only about 10% of the people. So it's not a high percentage, but it's high enough that I always like to tell people that, hey, this is a potential. And just, if this occurs, don't run for Prozac, meditate or exercise, or do some better self-management with breath that helps you get through these bumpy roads. Again, only about 10% of the people have that issue.
So just in case folks aren't familiar, Dr. Baric referenced benzodiazepines. These are habit-forming medicines that are used as anxiolytics. They're I think, particularly out of favor because we understand that they're habit-forming and people can develop a dependence on them. But they're things like Xanax or Klonopin, something like that. They're typically prescribed. Some people are still prescribing them for sleep. We know that they don't promote high quality restorative sleep. So people may be falling asleep, but they don't necessarily wake up and have their brain feeling like they're refreshed. And then chronic use of these medicines may be related to long-term neurocognitive decline, like dementia, et cetera. So I'm absolutely with Dr. Baric that we don't want to be using these medicines. None of my people are getting these medicines from me, but just to make sure if you're on them from another healthcare provider, what he's talking about when he references benzodiazepines. I just wanted to clarify that. So you mentioned at some point talking about looking for a 20% difference between scan 1 and scan 2. And I'm just wondering if you could talk about that. 20% doesn't sound wildly different, but I'm wondering if that's 20% on a scan represents maybe 70% change in a human's experience. So maybe you can talk about effectiveness and maybe put that 20% in a little bit more context.
Okay, so I tell people I want 20% or greater. Usually I'm seeing in the world of neuroplasticity 30 to 40%. So I'm really I'm hedging my bet because I'm seeing 30 to 40% most of the time. But I don't want to say 40% when they get 37. Now they're not happy. So you can't really connect the neuroplasticity to the symptom. Historically, at the session 20, people are seeing 50+% improvement in their self-reported symptoms. And that's going to be my anxiety's down. I'm working with my med doc to reduce meds. I'm seeing these lifestyle changes. I'm back in public. I'm going to the grocery store. I'm traveling again. So they're seeing real world improvement, but there's still improvement to be made. Mm-hmm. But they're seeing it both in their subjective world and the people around them. It's I call it the question. I says around session 10 to 15, you'll start getting the question from your coworkers. And it'll be like, Dr. Watson, what are you doing? Why, what do you mean? It's like, no, you're different. What are you doing? Something's going on. So yeah, I mean, the subjective changes are 30 to 50%, but the neuroplasticity, the brain changes, I mean, 20% is really my basement floor. Most people I expect between 30 to 40.
And you talked a lot about, doing this initial assessment or trying to get a personalized, individualized approach. We're not saying everybody has a size 7 shoe. Can you talk a little bit about, so we're going to do this initial assessment. Hey, 25% of people may not be a candidate. About 75% of people are a candidate. Do we see any commonalities in that group of 25% that don't tend to respond very well? Are there certain characteristics that might make you think someone might be falling in that group? Or is it, you obviously are going to scan everybody, but I just kind of wondered if there was a trend there.
Okay, so in your population of patients, and I'm telling you know this 100%, functional hypothyroid is rampant. And again, it's the mama scenario. If your thyroid ain't happy, ain't nobody happy. And when I look at an individual and they only have medial eyebrow but no lateral eyebrow, they're cold all the time. They're screaming all those hypothyroid issues. And surprise, surprise, but they come to us and say, well, my blood work was normal. What did they do? TSH and free T4, which tells you nothing, right? So you see the thyroid involvement frequently. So the big three are going to be thyroid, endocrine, it's going to be gut. So it's going to be some type of a food allergy, because where does all the base of the neurotransmitters start to get formed for your serotonin and dopamine and GABA? It all comes out of the gut. And so either we have a systemic inflammation, or the third is they have an environmental toxin. They have Lyme's disease. They're in a mold exposure continuum. All of those are all neurotoxins. So that's where I put my history on and say, let's dig more. Let's send out the LabCorp. Let's get IgG blood testing to see what 5 or 10 foods you cannot eat. Let's clean your gut up. And at the same time, we're cleaning the gut up, or we're working with their functional med doc, or yourself to you're managing the unknowns. But when I do the scan, I call it, I got the check engine. It doesn't tell me what's wrong. It just tells me we need to dig farther than the standard physical cholesterol.
Right.
That's nice, but we got a problem. We need to dig deeper. And then oftentimes in thyroid, TSH and free T4, well, those are nice, but we need 15 indicators to see thyroid.
Right. So here's another question. In terms of, there's so many wearables now, right? Like I feel like the Bionic Woman with my Alpha Watch and my Aura Ring on, right? And people are measuring heart rate variability and looking at their sleep quality and all these things. Are you seeing those indicators change, particularly heart rate variability, as people progress through this?
So I haven't tracked heart rate variability. I can just share, I wear a smartwatch and my resting heart rate is about 50, 51. But when I do alpha-theta training, which I referenced earlier, I'll hit 39.
Wow.
Regular. So, again, I'm 39, 40 is common. So my heart rate will drop 25% when I'm doing those sessions, that's a crazy number. That's a crazy number. I have not tracked heart rate variability pre-post. But again, very few people complain to me and say, I'm sleeping too well, make it stop.
Right.
No, please, I'm rested. I'd like to be exhausted and feel like I slept on a bus from LA.
Right.
Or on a red eye. So, and that's where, from your perspective, is you're seeing the importance of balancing out these hormones in this estrogen-filled world we live in, and how just absolutely critical it is. But there can be that brain portion that is still outstanding after you've balanced that. And those are the individuals, or they have that chemo-induced peripheral neuropathy, or they have that foggy brain. That it may be a brain functioning issue. Fortunately, it's not a tumor. Fortunately, it's not, meningitis, but they're definitely not optimized.
Well, I think that, the kind of cruel joke of menopause transition is that many women in this moment of their lives are dealing with launching children who may or may not be launching, and also dealing with elderly parents. And so it can be a tremendous time of stress. And then they're also usually at pretty high points in their careers, right? And so there's a lot of stress, even if everything medically is in place, that can really rock the boat. And it's just really nice to be able to offer people, hey, are you feeling like your brain isn't optimal? There's some ways that you can do this. And 20 weeks is not no time, but is a relatively short amount of time. And if you're going to compare that to sort of what's offered in the conventional space of, here, let's try SSRI of the day with a 6-week ramp up and a 6-week ramp down. There's 12 weeks right there. We may have to go through 2 or 3 meds before we find one that works, or we may give up because the side effects are so bad. I think this is really nice to have more tools in our toolbox to help folks during this potentially challenging moment, right? I think that just, like you say, life is really hard right now, but I think for midlife women, they've got a lot of plates in the air.
Oh, absolutely. And they, for the first time, they're hopefully putting themselves number one, but they have that teenager that has anxiety, depression. They have that parent that has dementia at 65 or 70, and they're saying, oh my gosh, what can I do I don't want to go that route. Mm-hmm. So, it's if you read Perlmutter and the various other neurologists, if you're not actively addressing dementia in your 50s, by the time you get to your 70s and your 80s, your whole house is on fire.
Yeah.
And it's really exciting to have, all individuals, but moms especially, that they're saying, look, I have to write everything down. I have to walk in their room and say, Alexa, why am I in this room? And when you can give them cognitive kind of memory tests and then work on their brain and then retest it, they say, oh my gosh, I can now go to the grocery store without a list. I could never do that before. One woman specifically, she's now taking tap dance and Irish dance because she saw that physically I need to challenge my brain. So we really challenged her to physically push her out of her comfort zone. So again, your life is as good as your brain is strong. The better your brain works, the easier life is.
Yeah, absolutely. So I'd love to open this up to questions. If people want to put in questions in the Q&A, let's see, I'm going to pull up Q&A. So you can just type your questions in the Q&A and then I can read them off. So feel free to jump in and put some questions in the Q&A. While you guys are thinking of questions, I have one. So I'm learning about all of this stuff, right? There's a device that my functional medicine mentor uses and likes called alpha-stem, which is used a lot in the military for anxiety, depression, and insomnia. Are you familiar with that device at all? Can you speak to that at all?
I've heard of it. I have no personal experience.
Okay. So we've got 2 questions that come in. Kimberly's just asking what your brain website is. So she wrote migrainedoctor.com. She can't open the website. Is that the right website?
Yeah, that's the correct website. And yes, they had a technical issue yesterday.
So okay. So stay tuned.
They were transferring. We made some changes. Accurate, but it should be later this week. Sorry about that.
Okay, cool. And then we will, when we post this lecture, we will make sure we post your contact information as well so that that'll be correct. There's a question about cost. So maybe you could talk a little bit about that.
Okay. So originally, I was in insurance with Neurofeedback, and some plans cover neurofeedback. But the problem quickly occurred where, think of if you're going to the gym. Neurofeedback, they would authorize 6 visits. Great. I send them 6 sessions. I send that to the HMO, the whoever, and 2 months later they get back and say, we're going to give you 4 more. So I could never get continuity with managed care. That's why we do not use, I'm not in managed care. HSAs, MSAs, yes. If you're doing 40 sessions, it's about $110 a session. So people will either do a one-time payment, get 10% off, or they'll do a payment plan. And they'll just spread it out over 12, 13 months. Correct. Would I love to get it less expensive? Yes. Are we the least expensive in the whole triangle? Yes. And we're using the latest technology. So we have the latest technology, but I don't really know how to lower the price without sacrificing results.
And is the cost the same if you come in the office or you take the device home, or is the cost more if you rent the device? Can you talk about that a little bit?
So the people that are remote training, we call them, they come in and there's just a deposit for the equipment, but the price is the same. And the joy of that is they're not driving. Again, so we have people, South Carolina, Poland right now, LA, spread out really across country and basically Europe.
Okay. There's a question. Do you work with folks currently suffering from panic attacks? And she writes in parentheses, bad enough that they have trouble leaving the house / grocery shopping?
And the answer is yes. Panic attacks are usually associated with anxiety, and they're oftentimes connected. And that is what really allowed the remote training to occur. So you come in, you do the initial scan in the office, and I realize that's undesirable, but then they take the equipment home. We have one gentleman who's now driving. He was 55 years old. He couldn't drive due to anxiety and panic attacks. And another woman, and I talked about going to the grocery store. She could only go to the grocery store at 2 a.m. because of that was when it was the most open. And now she just actually got back from Disney. So she went from paralyzed grocery store, should walk in if there were 4 cars in the parking lot, should leave, to she just got back from Disney. So panic attacks are usually associated or connected with anxiety. And when you improve the anxiety, the panic attacks oftentimes are greatly reduced to the point of being eliminated.
Great. Someone else is asking, can more than one person within a household use the same remote system?
Yes. So what will happen is mom will bring in ADD child A, and then mom says, oh my gosh, I'm seeing that your anxiety is going down. I want to be treated also. It is a different program. Go back. It is the same device, but they are on very different specific protocols, what we're trying to do. Because I mean, I could move the front of the brain. The one size fits all, everybody gets that same shoe size in the same spot. I might be doing only delta and theta up and alpha down, whereas they're just all trying to reduce them all. So again, it's very, very, very specific by location. But yes, a remote unit can be used by multiple people without location.
I think the question that they're not asking is, I'm assuming that the cost is per session, so that you couldn't necessarily say, we're going to use this unit for everybody in my family, and that we're going to do it all for one price, that because each person's going to have a different protocol, it's going to be the same price for each person. Is that correct?
Correct. So you're accurate. Each person has their basic own account that they're using their own purchased sessions. They're specific. So it's not like a one size fits all. Everybody use it while it's in that person's possession.
Right. Okay, cool. And this last person is just kind of a positive testimonial. So she's a person who's saying that she's just finished 20 sessions with you, 10 regular and 10 with alpha-theta. She feels very calm and less reactive to stress. I will say that I saw this person today and I was really impressed by what was going on in her life and how level she was. She says, in addition, her son has completed 40 sessions to address anxiety and depression, and his anxiety has improved tremendously. His depression has also improved, but he's still working on it. They're really happy and would recommend this. So there's just some positive vibes coming your way from someone who's worked with you. The last question I have is, have any of your patients expressed they are really tired after a session? My daughter found this when she was going for ADD, wondered if this was normal.
Okay, so the answer is I'm giving your brain an SAT test. When you're just mindlessly watching television, I'm really pushing your subconscious brain. And that's the art. The art is, I want to make progress, but I don't want you to come out like you've just taken a huge test. Mm-hmm. And that is where that talking feedback from the individual to the clinician, Ellie, I'm leaving tired, and for the next 2 or 3 hours, I just want to go take a nap. I have too much weight on the bar. Right? I can go lighter. I can make the brain be rewarded at a higher percentage. So then that individual's brain isn't being so exhausted.
That makes a lot of sense. And so what I think I'm hearing is, it's not necessarily like you have this assessment and then there's no communication back and forth, but like that would be a reason to reach out and say, hey, I did my session at home or whatever, this is what I'm experiencing. And you may say, cool, we're pushing you too hard. We need to back off a little bit.
Right. We're still making progress. It's just going to be a little bit slower. And that might be a few percentage points, but we're still 95% going forward.
Right.
And I mean, people have to function in life, right? Are they going to school? Are they doing homework? Are they doing whatever? We want them to give a workout, but we want them to still be able to scratch their nose when they get out of the gym, right? If we work them out too hard, they can't, do anything. So yeah, that's the art. The art is I want to have progress without mentally exhausting the brain. And that's pretty rare.
Yeah. One thing that came up with someone who's not here, but just in case others are wondering, sometimes if you're going to go think about QEEG, maybe you have some depression, maybe you have some anxiety, maybe you have a headache, whatever. So someone in our community had a really bad migraine that her time was to go get her QEEG assessment. And so that was a question that Dr. Baric and I talked about before was, if you're not having a good day, do you have to reschedule and try to find a good day? And I think your answer was that no, there's not a huge difference if you're having a headache or you're having a whatever. So maybe you could talk about that a little bit. Like, is there any reason, like when someone was not having a good day, that it really doesn't make sense for them to move forward with the assessment? Or is most of the time people can just go ahead and have their assessment?
Okay, so I think there's a scale there, Dr. Watson. This person's having migraine and they're throwing up in the bathroom. This is your quality time at home, right? Right. That's not the time to come in. Right. Hey, I have a headache and I'm not as well as I could be. You're fine. So you're full blown COVID. Yeah, you should probably stay at home.
Yeah, I'm sorry. That sounded
the vast
silly,
majority.
Okay.
I'm sorry.
No, I'm sorry. That sounded silly. Maybe we could not take it in. Obviously, if you're acutely ill, they shouldn't. We're trying to be respectful of others and not spread illness. Let's put it in sort of a psychosocial emotional thing. Let's say your dog died and you were feeling sad and you were feeling out of sorts because your dog died and that was a really special animal in your life. Would you want to have that person reschedule the appointment when they were having a more neurotypical day for themselves, or could they come in even though they were kind of having an acutely sad day? You're frozen right now. Okay.
Okay. So I heard most of your thing. If that scenario where a family member dies, a dog dies, something high traumatic, we just have them wait a week.
Mm-hmm.
right? Get through your worst dark clouds. Yes, things are not resolved in a week by any means, but your brain, you know, when you're to that extreme, yes, there could be changes on the QEEG. Are we going to be extremely accurate still? But why not try to get it as most accurate? Because it's not like it's a life or death test that we have to have at that moment.
Okay, that makes sense. This is a complicated question. What is your approach for someone with a family history of dementia or Alzheimer's? Then the second part is, how long do you need to do the treatment, and how do you know if it's effective? So.
All right. So this is, believe it or not, as we age, our brain loses connection to our body. And this is just my clinical experience. If you watch a person walk and they do not swing their arms, their brain does not know where their body is. Mm-hmm. That is, those are the ones that respond the absolute worst. And I'll end with the reason why I got into neurofeedback. My mother had a stroke, and we basically recovered her at 80. But if they have some level of neurointegration and they come in, we do the QEEG, but we also give them a memory test. And this is the most painful memory test you've ever taken, because they see us, even us, how many numbers you can say backwards before your brain breaks. And 1, 2, okay, 1, 2. Now say it backwards. 2, 1, okay, got it. Now if I start giving you a telephone number back, holy heck, I don't know what that is. So we give them as many objective tests as we can. We give them the QEEG. We work 20 sessions, and then we retest. And again, this is the data point. What are you seeing? What are the individuals seeing in this person's life? What's the individual seeing? What are the people around them? What's the data show us? But people that are basically sedentary, it is much harder than if we can get them to be short of breath 5 to 10 minutes a few times a week. If we can get more blood flow going and they're in a good metabolic state, yes. There's been some really, really amazing recoveries with dementia, Alzheimer's. But if they're basically watching TV all day long, and when they walk, they have a plastic face and they don't swing their arms, not the miracle worker. Those are difficult.
Right.
Stroke, just.
Go ahead.
I'm sorry, real quick. So 7, 8 years ago, my mother, 79 at the time, stroke, could not care for herself, dress herself, shower, feed. A year post-stroke to a 79-year-old, I was able to start working with her for neurofeedback. Got her off the walker, could sit, stand, could drive, could feed, could dress, could care for herself. She's never going to be independent, but her quality of life and her quality of her family's life went through the sky. So that was kind of one of the main reasons. And then the other one was a patient came to me and said, my child's on Adderall, but he hears voices, and he wanted to help. How do I? And I was unfamiliar with neurofeedback at the time, and sadly, those voices talked him into hurting himself, and he's no longer with us. Mm-hmm. So those were kind of two reasons to say, gosh darn it, this needs to be known by people. And thank you, Dr. Watson, for inviting me here. It is a tool in the toolbox. It's not a fix-all, but it is a tool in the toolbox that is diagnostic and pragmatic as we can, with really long-term changing results for many people. Any other questions?
I think this has been really great. Thank you so much for sharing your time and expertise with us. We've gotten through all of our questions, and we will share this with you in your office, and then we'll post it on our public stuff that's free for everybody. But we'll definitely be sending patients to this interview so that when it seems like people are a really good candidate, they can kind of meet you virtually and see what this is like, so that when they're ready to reach out, they are that much further along.
Well, thank you very much, and be well, everybody, and try to keep your brain in a good space in the crazy world we live in.
All right. Thanks so much. Have a great day.
Bye.
Bye.